How do biomarkers in lung cancer affect treatment options for lung cancer patients?
So it used to only be in stage 4, but now we are learning that biomarker testing is really important from the get-go because we have induction or neoadjuvant protocols that are looking at giving targeted therapy before patients go to surgery. We know that there's FDA approval for patients to get targeted therapy after surgery, and there's a survival advantage there. So make sure that you have next generation sequencing testing regardless of your stage.
Okay, that's good advice. So we've heard how testing and a patient's individual disease can lead to more targeted options. And you just mentioned targeted therapies. How do they work?
So there's many different targeted therapies that we have. Some are given as an infusion. For HER2, for example, we have TDXD and we have TDM1. TDXD is the only drug that's FDA approved in this setting. There are clinical trials looking at TDM1. For EGFR exon 20, we have another infusional drug called amivantamab. For EGFR exon 19 and exon 21, we have a pill called osimertinib. For KRAS, there's a pill. For most of the driver alterations, it's a pill, but some of them it does require infusional therapy. But these are therapies that are targeted at the cells that harbor that mutation.
Let's turn to immunotherapy. What is it and how does it work?
So immunotherapy is basically teaching your body to recognize cancer as foreign. So when you have, I always kind of use this hand model. So basically a normal cell has, let's say, 3 prongs. And then sometimes what happens is cancer will grow a marker called PD-L1 that makes it hide from the immune system. So the body thinks that this is a normal cell. So what immunotherapy does is it comes and it sort of puts a cap on that PD-L1 so that the cell looks foreign again and the body can attack that cell and get rid of it. So it's almost like ramping up your immune system to recognize that marker and get rid of that cell.
What is the regimen for immunotherapy and how often is treatment administered?
So immunotherapy is approved in, the neoadjuvant setting, which means before chemotherapy, it's approved after chemotherapy, and it's approved in the stage 4 setting. There's many different regimens and many different dosings and many different drugs, but it's typically given in your veins either once every 3 weeks or once every 4 weeks for a certain amount of time. If it's given in the curative setting and it's given indefinitely or until there's disease progression or intolerance in the stage 4 setting.
Okay. Let's touch upon the side effects of these types of treatment. You've mentioned that there are so many, but what are some of the major side effects and how are they managed?
Side effects of immunotherapy can include pneumonitis, which is inflammation of the lungs, any kind of endocrinopathy, like issues with your thyroid, issues with your pancreas, like diabetes. It can cause colitis, which is diarrhea, inflammation of the colon, hepatitis, inflammation of the liver. It can cause cerebritis, inflammation of the brain. It can cause arthritis or arthralgias, inflammation of the bones, and it can also cause rash and fatigue. Typically, if it's the thyroid, it's managed with thyroid replacement hormone or a drug that would calm down the thyroid if it's overactive. Pneumonitis is steroids. Hepatitis is sometimes treated with steroids. Colitis, steroids typically. Steroids usually come somewhere in there, usually not with the endocrinopathies, but the other itises, it's typically we start with steroids and go up from there. And the goal is to really recognize these toxicities before they become a problem and just at the glimmer of them just starting.
So would you consider these treatments to be personalized medicine then?
So it's personalized in the sense that if someone has a high PD-L1 expression, there may be some data to demonstrate that they may benefit from immunotherapy or have a response. If someone can't tolerate chemotherapy, or is not interested in chemotherapy or has other reasons that may preclude them from getting it, it might be reasonable. So in that sense, it is considered personalized.
How would you define personalized medicine?
To me, personalized medicine takes into account, the biologic makeup of a patient's disease, like if they have a mutation, what their PD-L1 status is, what the histologic makeup of it, what's their stage. And then on the other hand, what's important to that patient. If they're a tailor, you want to make sure you're not giving them a medication that's going to cause neuropathy so they can't use their hands. If they're, they enjoy playing the harp or the piano, same thing. If their goal is to like continue to run marathons, you may want to avoid something that's going to cause inflammation of the lungs and risk them for pneumonitis. Tailoring to make sure that the treatment is part of their life but does not become their life.